This week on the BackTable Podcast.
It's the startup rodeo. You go start a company, try to hang on for 8 years as you spend all your money, all your family's money, all your friends' money, all your friends' money. You know, everything's at risk, and you've got 8 years to kind of get out the chute the other side. And so it's a wild ride.
I think Joey said that you had a saying: every successful startup medical device company dies 100 deaths. Was that you, or is it?
Yeah.
It makes sense.
And that's a little bit of the ground up approach. You know, it's not, well, we've got the answer, we're going to fit it into things. So that is tough to make work. This was where you just keep going, you keep solving problems, and that's what makes it work.
Hey everyone, and welcome to the BackTable Innovation Podcast. You can find all previous episodes of our podcast on iTunes, Spotify, and on BackTable.com. This is our next installment in the BackTable Innovation Show, where you will hear stories from physician entrepreneurs who are helping to drive healthcare forward through MedTech innovation. First, a brief message from our sponsor. Trying is believing. Nothing compares to trying a device in your own procedures and with your own patients. That's why Medtronic invites you to experience the Arterial stent and see what makes it different. Learn more about Abre at www.medtronic.com/Abre stent. Now, back to the episode. Today we're going to be discussing innovation in vascular access for dialysis patients. Specifically, we're going to hear about the Ellipsys story, the Ellipsys Percutaneous Endo AVF system. Very pleased to introduce our guest, Dr. Jeffrey Hull. Welcome, Jeff, to the show.
Hey, thanks, Fritz. Good to be here.
Yeah, we got to meet briefly at the last SIR in Salt Lake City, and it was a big table, kind of a who's who in IR table. It was kind of intimidating, but it was great to meet you there and talk to some of the other folks at that table, including Joey Steele.
Yeah, a lot of fun. I think we had Mike Watts there and Nick Petruzzi. Yeah, good group.
Yeah, Mary Constantino was there. She's the one that pulled us over, and Sabine was there, and yeah, definitely a colorful crowd. But well, Jeff, excited to hear this story. But first, the way I like to start these out is, for you just to tell us a little bit about your background, where you were in your career when the original idea for the device came about. But are you also just tell us our audience, are you still practicing? How long have you been doing IR for?
I actually finished residency in 1989. Then I went to Naval Hospital in San Diego from 89 to 93. Was one of the IR people there. Worked closely with UCSD folks, which was Ian Roberts and Karen Valji, great group. So they really helped train me. I never did a fellowship, as it turns out. So I kind of OJT. And then I took a full-time job in Richmond. And I'd been there for 20 years. And I know golf is like a huge waste of time, but one of my golfing buddies was friends with Steve Parker. Steve Parker developed the mammotome, which was the breast biopsy needle. So Steve and my buddy Chris Young developed the anchor that allowed you to do arthroscopic repair of rotator cuff injuries. And so Chris is standing in front of my office and says, what's something in your field that you would be greatly improved by making it minimally invasive? And it had to have additional requirements, which were, you had to do 100,000 of them needed to be done a year. They needed to cost more than $1,000. And the way it's been done now can't have changed in 25 to 50 years. And my immediate response was, AV fistula. That was something that, it's interesting at the time, all the AV fistula work had moved out of the hospital and out into outpatient labs. And so we weren't really doing a lot of it. But that was sort of the key point. And that's the only reason I tell the story, is that a lot of people start with an idea. I have this idea to do thrombectomy. The problem with that is now you're trying to find a market, you're trying to fit your technology into the landscape. The way we started this company was, we want to do this really great thing, which was to improve creating fistulas, make it percutaneous. And we didn't have any preconceived notions on how we were going to do that or what was required to do that. And so it allows you to sort of work through the steps and come up with the best answer. as opposed to your answer.
Yeah. And what year was that when he...
That was 2006.
It was 2006. And at the time, you were in the hospital. It sounds like you were doing just hospital
practice
work.
Yes.
Hospital practice. Were you doing both IR and DR work at the time?
No, when I left San Diego, I came to the East Coast really taking a job that only required me to do IR.
100% IR.
100% IR the whole time, yeah.
Yeah, and I did fellowship in 2012, and at that time, I remember, this is at Vanderbilt, we did do a fair amount of dialysis work, but I remember at that time, my attendings being like, a lot of this is moving into the outpatient. We're seeing less and less of it. They're like, we used to do these all day, every day. And, and I still got a good experience doing the dialysis work, but it was basically all the patients that the surgeons didn't want to see, right? We were obviously doing the 5 o'clock declots and that sort of thing.
Right. They couldn't get taken care of somewhere else.
Right.
Things weren't going well. It was in the evening, also on the weekend. Et cetera. Yeah. That's the story.
It was kind of a dumping ground for those patients. I remember I was talking to Reed Omery about it. He's like, it's really sad because these patients literally just get dumped at the hospital door. So they were always kind of, they were the more tricky ones and complicated ones. And so anyway, I remember we had that similar conversation. Like these haven't changed in decades, the way that these are created and like you were just saying.
And the care the patients were getting, which turns out to be a really critical point of the whole making it faster, better, cheaper, making it simpler. It's like, well, one of the key drivers was to move it into the OBL. So I actually opened an OBL in 2010 specifically so I could have a dialysis population to treat, because that's where the work was done. And it really turned out it's really the key to percutaneous fistula creation. You see the patients in the office, you do the procedure, you follow them up, everything is super easy for them. So we could typically get a fistula placed in and cannulated in the amount of time it took to see a surgeon.
Yeah, exactly. And so the timing wise, it was 2006 when you started having the conversation, 2010 you opened the OBL. Were you trying to create that patient population so that you knew you were going to create this technology and you wanted to be able to have that patient populated?
So now you have, we want to create a percutaneous fistula. And so I'll back you up just a little bit. So I went to Duke for medical school and I did my research year. At Duke, you do a year of research, your third year. And so I did it in cardiovascular surgery. I was very interested in that, but with my Navy commitment, my mentor there said, hey, this is going to take too long. You should do something else. And he said, the new surgery really is radiology. They got MRI. MRI was just coming out, and this is in the 80s. So I did. I went that direction, and I actually went to Emory because Grudzik was there. And of course, he died before I got there, so it was not, I never got to really know him, but that was sort of a hotbed of interventional radiology at the time. And I went into radiology specifically to become an interventional radiologist. But that research in Duke was really critical because I was studying AFib, and you would do these dog lab things and you put a sock on the heart and you trace all the arrhythmias and all that. And then you'd sterilize the thing and 2 weeks later, you're doing it in a human. It's sort of like, there's sort of this narrow band between like experimentation and then use in human
implementation
at these basic levels, which is not a lot of experience a lot of people have. But one of the things that had always fascinated me was the anastomosis. And, how do you, it takes a long time. It has to be done perfect. And there was, end to end, side to side, end to side. And the idea that you could do it mechanically and percutaneously was very appealing to me. And then the fistula was the easy place to start doing it. So in the back of my mind, there was always this, interest in an anastomosis. And so so that there's sort of an extra layer there that behind my answer about,
well,
hey, let's do any fistulas.
Did you have an engineering background or anything?
No, I was biochemistry.
Okay.
Went to the University of Colorado, which some people don't count as college, but it was a lot of fun.
My brother went there, so I know what you mean. No, we used to go visit him all the time. It's a great spot. So also to kind of back up, I mean, you guys had this idea, you know, where that conversation went after you said, well, the answer is, not easy, but the answer is let's innovate on AV fistulas. Let's have this percutaneous solution. Where did you guys go from there? Did you go to the lab and start playing with stuff? I mean, like Julio Palma's in his story, he starts like playing with stuff in his garage. What was your next step?
Yeah. So there's two things. One is you get a notebook and you start writing down your ideas, so, okay, you're going to do this. Where, how, what, start putting together a couple of ideas. And then, in like this whole process, you got to sell the thing all the time. You're selling all the time. So I've got to convince, Mark Richard and Ed Chang, who end up being the CEO and the head of marketing for Avenue, hey, that this is a good problem statement, that it's possible from many things, and I'll kind of bore you with that a little bit, but there were so many cool things you had to work out. And if you just think about it, it's like, where are you going to do this? At the time, nobody we knew of was doing percutaneous fistula. So, were we going to take a vein and drag it over to an artery? I mean, how were we going to make this happen? So that was a big problem. And we thought of all these things we were going to do. And once the guys got a little bit interested, they started looking at the problem statement from the back end. It's like, well, this really is a big problem. There's hundreds of thousands of these. There's 100,000 of these done every year. It's a big caseload, underserved, hasn't changed. It met their criteria, and they were looking for a company to start. So we start working on the where and how. And one of the really cool experiences for me personally was I started looking at all this anatomy, and I went. Do you remember where they had the visible human exhibit that went around the country?
Yeah. Where did I saw it? I think here in San Diego.
Okay. It was in New York City at the time. And so I go there and I start looking at the arms and the veins. I'm like, where are we going to do this? How am I going to get a vein over here? And how am I going to get the right vein? And there was, you see these pictures, the arteries and veins, and it looked like this perforating vein connected the deep and superficial system and came right by the radial artery. And then as it turns out, if you look at the literature, there was a 2-page article that basically drew a picture of it, back from 1977. And the Grazi fistula, he described it, but he connected the perforating vein to a number of things. But then there was, and I forget the name, but we might have to add this later, but this one little 2-pager had all the anatomy, all the stuff you needed to know. It's like, that's it, So then we started ultrasounding everybody to see, well, who has this anatomy? How common is it? And what does it really look like? And then we basically did an anatomic study and found that 88% of patients had a perforating vein that was visible and came down and touched the radial artery. So it got rid of the problem of harvesting a vein and moving it. So now it's like, okay, we're just going to connect that vein to that artery. And so then we started working on the physiology of welding, and that was a lot of animal work, et cetera, et cetera. And that was our first patent. It was like, okay, we're going to weld these together. One of the other principles that the team, Mark Richard and Steve Parker, Ed Chang, was that they didn't want to leave anything behind, because once you start leaving stuff behind, it immediately becomes an IDE, and at the highest level. So you really, and you have to do a lot of biocompatibility, and there's just a lot of stuff. So if we could figure out a way to do it, and as it turns out, laparoscopically, people were ligating and dividing vessels with ligature and, with heat and energy. And so what kind of energy would work best? So we ended up choosing thermal resistance because it works really well in puddles of blood, and it works well in calcium, unlike RF. RF goes around calcium. So, if you have a heavily calcified artery, it'll burn something next to it as opposed to welding through it. So this actually welded calcium well. So, and then it was like, well, is side to side good enough, or does it have to be end side? And then we did computational fluid dynamics studies. And so you end up doing all this like basic research, animal work. And that was really fun. As a physician, that's super cool. And then you have, once you have a prototype, you got to make it work in a human. You take it, so we ended up going down to Columbia at Cali, and we working with a team down there. And
what year was that?
Oh, that was the first case we did was in 2013. So the animal work took forever. It's hard. One, the animal model really wasn't ideal. Hard to find an animal with the vein on top of the artery. So sheep, it's on the side. So you didn't really approximate what we were trying to do, where in human, the vein's always on top of the artery. So getting to it was a little bit tough. And then, you perfect it in a sheep, that doesn't mean it'll work in humans. So, at some point you have to say, okay, we have a pretty good idea how this works, but we're going to have to, do a feasibility study in humans.
How many years did the animal studies take, roughly?
So 2010 we did our first human 2013. We always used the animal model. We used it for training. And so it never really went away. We were always trying to perfect the welding and kind of get all that right, So,
how did that first trial in human go in Columbia?
Well, I mean, we wrote it up. I think we put it in JVIR, as an abstract. We did, I think it was 14 patients, but, we had some that went 10 minutes and some that took a couple hours, What you don't know is kind of in your mind, you say, oh, we'll stick high and then we'll put a sheath in and then we'll walk down the vein. It's like, well, it doesn't really work because there's so much vasospasm in a lot of patients that once you put the sheath in, everything was lost. And we also were using fluoro to a certain extent to figure out where to go initially. And the problem is the vein you're in goes into spasm, and there are probably 9 or 10 veins that you can go down. You can go down the ulnar, you can go down the interosseous, you can go down the radial, you can go up brachial. All these, the wire goes everywhere except for where you want it to go. And then we realized that the way to get it to go where you want it to go was to use ultrasound. And then we stopped using the wire altogether and stopped putting a sheath in because of the spasm, and realized if you just stuck the vein and were careful not to hit the wall and cause spasm, you could walk the needle all the way down to the artery and then just stick it. So that ended up being the technique, but we had to work that out. It took a while, by the time we did, after the initial feasibility trial, we did a more formal trial in Monterrey, Mexico with Guillermo Alessandro, but then we had the technique of walking the needle down.
Yeah. Anybody who's done even lower leg vein work knows that,
yes. Right.
Those things spasm up pretty quick. So there was an article that I read in Endovascular Today in 2015 alongside, it was you alongside Dheeraj Rajan with the Everlink system, which later became the Wavelink, right?
Right.
Yeah. And so I think a lot of people are curious is like, how was that developing along the same time? Because both products kind of hit the market at a similar time, right?
Yeah. There's a lot of interesting back and forth there. And that would take a whole nother show to kind of hit all those highlights.
Yeah.
But so Tom Fogarty was involved with our guys. And so our guys are telling Tom, hey, we want to do this percutaneous fistula thing. And Tom's like, if you want to do fistulas, you got to have a wrist solution. And so my team is like, well, Jeff, we're not going to start the company unless you come up with a way to do this in the wrist. And so that's when we started looking at the snuff box. And then we realized that the snuff box, there's a vein and an artery that are close together, and they're close enough to meet our tolerances that we found in the animal lab, which is 0.5 millimeter or 0.5 centimeter. But for this anatomic study, finding the snuff box as a wrist solution, we were kind of dead in the water again. And what I often say about this is, well, there's two things I like to say about. One is like death by a million paper cuts. If you don't solve this problem, you're done. If you don't solve this problem, you're done. And the other way to describe it is, it's the startup rodeo. You go start a company, try to hang on for 8 years as you spend all your money, all your family's money, all your friends' money, all your friends' money. Everything's at risk, and you've got 8 years to kind of get out the chute the other side. And so it's a wild ride.
I think Joey said that you had a saying: every successful startup medical device company dies 100 deaths. Was that you, or is it?
Yeah.
It makes sense.
And that's a little bit of the ground up approach. It's not, well, we've got the answer, we're going to fit it into things. So that is tough to make work. This was where you just keep going, you keep solving problems, and that's what makes it work.
Yeah, and it's the journey. I mean, you eventually had a successful exit and everything, but I think just going through the startup journey with BackTable, it is the journey that is the successful part. I mean, as long as you're making something that people are using in medicine, I mean, that is a success in itself. And whether you have this exit and all that stuff, I mean, that's great. But then what are you going to do after that? And then, I mean, in your case, you went on to do more in the field, but I think the thing that people don't appreciate is the journey itself and all the little successes and failures.
And how much fun it is. I mean,
yeah, exactly.
It really made, so I was 48 when we started this whole thing. And it was about the right time in your career. If you're really young, you don't know enough. And as you get a little older, you don't have the horsepower to get through the 8 years.
It's true. They say that's a sweet spot. Tony Fadell, who was the guy who helped invent the iPod and iPhone, he says that most successful startups are founders in their mid to late 40s because they've already gone through all the failures of youth, but they still have the energy to put into something, and so they just learn from their life experience.
And you kind of have to be on top of yourself. I mean, you can't be a brat. You can't be too overly emotional. You have to work with a lot of other people. You have to
leave your ego at the door.
You have to mature a little bit.
Yeah. Well, on that note, one question I have for you is, how did you find you? I mean, you mentioned some big names, but how did you find seasoned veterans to help you along the way? I mean, was this part of your network at the time, or?
Right. I mean, my golfing buddy, right? So it's good, everything comes back to golf and not really. So, these are a lot of, what I think a lot of people don't realize is there's a lot of smart people looking for the right project. And so, they, in an indirect way, they found me. They were looking for a good company to start that met their problem statement criteria, which, if you remember back, $100,000, hasn't changed in 30 years. Find something that you can really improve. And because it takes a long time and a lot of money to solve the problem, and you don't want to get to the finish line and find out that they've cured kidney disease. I mean, actually it'd be nice if they did, but you're working towards, you have to go out and raise money, and you have to, and that's what your CEOs do. And I talk to a lot of people that have ideas, and the typical pattern is someone has an idea. Every IR person I've ever met has a great idea. Now, the question is, does it fit those criteria that it's going to be something that you can turn into a company? And usually not. It's because they haven't really thought about it in that way. But a lot of people, the first thing they do is write a patent, and then they do the turtle move. I don't talk to anybody, and, talk to a few big companies, and don't want anyone to know what my idea is. And really, it's almost the other way. As soon as you have a really good idea, you should check with everybody, figure out whether it's a good idea, then go out and try and raise the $40 million to $50 million that it's going to cost you to get across the finish line. And someone may try and steal your ideas, but unless they got $50 million, they're not getting very far with it. So I think a lot of people overestimate how much they want to be CEO of a company, which is a totally different skill set from all the things we just talked about: anatomy, physiology, fluid dynamics, the intricacies of taking care of the patients. That was my side. I'm not a CEO. I'm not a marketing guy. You need those people to be successful. You need a lot of different people.
Yeah, and so that's what I'm always curious about, especially with physician founders, is how do you find your place in that company? You might have had the idea, it's your baby. Are you willing to give up that CEO, that sort of leadership? Even if you've cut back part-time clinically, how do you know where your skill set is best? Because if it's a lot of people think, well, if I'm not the CEO, then who am I? What am I? How did that unfold with you?
So I had mentors. I had guys who had done it before. Steve Parker, Chris Young. They had done exactly this with the same engineers and the same marketing people. So, and I'll just tell you, there's people out there that have 10 of these that they're incubating. That they provide engineering if you want it. They provide regulatory, and we haven't even gotten into all the other little non-science parts of this, which are FDA, regulatory, reimbursement. All these things I didn't know. I thought I knew a little bit about those things, but I know a lot more about them now, and they're just as important. And if doctors are not getting paid, they don't do stuff, even if it's the best thing in the world. You have to figure out the reimbursement.
Yeah, and like you say with those things, the FDA, the engineering, like you need subject matter experts for each of those things. And I see the other thing that physicians struggle with is outsourcing those kinds of things. They're like, oh, I'm going to just learn it all and I'm going to know it all because I'm smart and I'll figure it out. But really, like, that's not even.
We're trained to be independent. You go to medical school, it's like, doc, it's on you. Don't go to bed. You got to take care of this patient. You're the only person who can. So we're really good at isolating ourselves and putting everything on our own shoulders. But, so a little bit of a joke, it's a little like 100% of zero is zero. 5% of, $500,000 or $500 million is a lot of money. You don't want to exaggerate your worth. What you want to do is, you don't want to give the company away, but you're going to, what I would, in a really big idea, big company, as a founder, physician, if you walk away with 5%, you're doing really good.
Yeah. Well, that is incredible advice, because I oftentimes hear the opposite, where they're like, hold on to as much as you can, give away as little, but then you don't bring in the right team. You don't have the winning team,
And time is a really big enemy.
Yeah.
You're not making money. So even if your burn rate's slow, you're still spending money. And then when you start your clinical trial, the burn rate goes through the roof. So now you're, money out the window. You've got to keep the money coming in from investors while you're trying to get this thing done. And you need to be moving. 2 years is death. Yeah.
Right. Well, yeah, especially when you going back to the wavelength thing, like, were you guys neck and neck in terms of getting this product on the market?
Right. Oh yeah, that was kind of cool. So all of a sudden we realize, hey, we got a competitor. Someone else has come up with the same idea, and they came up a little bit different. They thought of it as, hey, when you got stabbed in the arm during the Civil War, you had a fistula created, and so how do we do that? For dialysis, and they tried it once and it didn't exactly work. So then they got cadavers and they injected, kind of like the thing with the human anatomy project that we talked about. They'd injected both the arteries and veins and then found, oh yeah, there's these perforating veins that connect the deep and superficial systems. All you have to do is connect these veins in situ. So it was, like most things, the time was ripe, so two slightly different ideas, but we both discovered the anatomy in different ways. I discovered it by ultrasound in the story I told you, hey, where are we going to do this? And looking by ultrasound and checking the literature, and they found it by injecting plastic into arteries and veins. And I may not have that story 100% correct, but that's my understanding of it.
Yeah. Still, it is very neat that it was happening along, kind of in parallel. Did you guys ever trade notes or anything, or was everybody kind of just in their silos?
There was like a little bit of people kind of being very careful about sharing notes and stuff. But I think you soon realize that for what I always used to say to people when they started getting hyper competitive, I said, if wavelength fails, that could take down the whole idea of percutaneous fistulas.
That's true.
So you don't really want them to fail. We want to be better than them perhaps, but we don't want them, they could take down the whole market, or vice versa. So a little competition is a good thing. It helps validate your idea. this idea was, I think, so unusual that when you told people that you were going to create an anastomosis by welding the artery and vein together, they really looked at you like you had 5 heads. And it just was hard for people to wrap their minds around. Whereas I think certain other ideas are very easy for people to wrap their minds around. And so when you really are challenging the system, it's a lot harder to sell your idea.
Yeah.
Does that make
disrupting.
sense?
Oh, absolutely. Yeah. You're disrupting the way, especially with that. That was one of my questions is like, who were your biggest critics? And not specifically names, but like, I imagine specialties. I imagine if you're pitching it to vascular surgeons, they're kind of like, why would I do that? But that's just
exactly.
Whereas IRs might get it because they're like, well, I want to do it endovascular. Of course, this makes sense, Yeah,
and I think so. Surgeons turned out to be, Alex Malios and Jaime Velez, 2 surgeons that, without them we never could have done it. Tib Jennings, who was he and Alex wrote one of the key from the University of Oklahoma, one of the key papers on the Gratz fistula. And they wrote up 1,000 patients, and they really understood the value of using the perforating vein and having multi-outflow fistulas. And that's a whole nother clinical and physiologic thing that we uncovered in the course of our clinical trial, and everyone else has come up with the same results over time. But there are benefits to having more than one channel. If you have just one channel, you tend to get more intimal hyperplasia, and it tends to wear the vein out. Multiple channels, it turns out to be a good thing. Though, of course, when we first realized that we were going to have multiple channels, we weren't so sure. You have to, that was another area that could have undermined us completely.
Yeah, and so was there a specialty or a group of people that were especially hard on y'all or like critical of the whole idea that made you feel kind of like, well, what are we doing the wrong thing?
Kind of, yes. I mean, there were people, I talked to some interventional nephrologists, and I would say, this is what we're going to do. And they'd be like, you can't do that. And then there's the other is, so I'll throw a little shade on the IRs. So the IRs, the first question they would ask is, what's that going to do to my relationship with my surgeon? Because I think most IRs, pretty much, that are doing vascular have an important relationship with the vascular surgery. You just don't exist in a vacuum. And I think that was, and then we didn't get as much traction with the IRs as I thought we would.
That's interesting. Yeah, that is the opposite of what I had said.
Yes.
What I was in thought would be the case.
The people we got all the traction from were the interventional nephrologists. They were, you have to realize there was a group of interventional nephrologists that went to Europe and learned how to do Gratz fistulas surgically. They were in Arizona. There's a big group there, but no one else followed. It was hard to do. You go from being a nephrologist to a surgeon. Everyone knows it's kind of like the old saw. Are you a medicine guy or a surgery guy? It's like, well, you usually pick the right fork when you were in medical school. So if you went, nephrology, you probably were not, surgical type, and vice versa. So for them, the interventional nephrologist, it was really appealing. And so we actually did the pivotal trial with 7 interventional nephrologists and myself.
Wasn't the guy Mala one of them?
Yeah, the guy was one. Yeah.
Yeah. He's been on our show a couple of times talking about Endovascular. Yeah. Because he's worked with both systems. And so he's very knowledgeable, and he's come on the show to talk about the differences between the two. And yeah, it is interesting to like kind of hear about where you got that positive feedback that keeps you going, gives you the energy, versus sometimes there's energy or feedback that kind of stalls you a little bit. And it could come from anywhere. It could come from even friends and family that don't quite understand why you're spending all this time and energy on such a thing.
Right. But boy, it was fun. I'll just tell you, it was fun. If anybody's thinking about, listening to this, thinking that they got an idea they want to pursue, they get on it. It's just well worth pursuing, as I'm sure you're finding with BackTable. What a great show this has turned out to be.
Yeah, no, and it's always evolving, right? Or always meeting new people and with new ideas, and it just the network it creates is pretty incredible. Like I was just talking to my program director the other day, he's like, Aaron, I'm thinking about jumping in, and I've had this idea for a device for a long time. Can you put me in touch with the right people, like, to help me out? And now, I've had people like you on the show, for a few years now, and Brian Hartley as well. And he did the Stanford Biodesign program, which is also a great resource for docs. Even if you don't want to take that time to do the program, just knowing people that have gone through the program because they've built out this network in the device space. I'm sure you've come across all those people, right?
Well, a lot of people run ideas by me, and I really enjoy that. So people run ideas by me all the time, and I give them the same advice we just, that we're talking about right now. It's just, it's like, okay, you've got this idea. You really need to move it to the next step, figure out how you're going to do it, and don't waste time. Come on. Yeah.
That's what, Rusty Hoffman was on, and he was saying, just do, like, you got to stop, like, mentally, masturbating about it, or like, a lot of people will get this, like, what is it? Analysis paralysis. We're like, well, I don't know. And then they just, and it stalls, and then they never end up doing it. And he's just like, you just got to do it.
Yeah. I mean, because you'll talk to someone and say, oh yeah, I patented this 10 years ago. And you're like, well, so we started the company and then we filed our first patent. It's like, because you want the patent to live as long as possible, so I love, the Marcus Aurelius. I don't know if the Stoics, the obstacle is the way, just take it head on,
Right.
That's
absolutely
right. But boy, it was fun. I'll just tell you, it was fun. If anybody's thinking about,
absolutely.
that's what innovation lives by. You got to just take it square on, solve the problem.
Yeah. And it sounds like the process and the experimentation, that was the part you liked. I don't want to say it was easy, but like when you really enjoy it, it feels easy, right? Because you're just like, you wake up and you're like, I want to tackle this. Whereas what were some of the things that maybe you didn't expect were harder than you thought, like the FDA approvals and stuff like that?
Right. So regulatory, so there's one of the things that you soon learn is that because you're so focused on FDA approval that, okay, now your device is approved, but it's a new device. It's something that's totally unique. So now there's no code for it.
Okay.
So now you're in the donut hole, which is you have FDA approval and you need 5 publications by separate authors, 3 of which have to be in the United States, to submit for CPT code.
Oh my gosh.
So, you're scrambling to get, your FDA trial done. And so, immediately after that, the next step is, well, you need 5 publications, one of which can be your pivotal trial, right? And so now you need data. You need experience. People need to be able to say how many hours it takes them to do it. And until that happens, it's tricky getting paid. Now you can get some technology pass-throughs now, where they'll agree to pay for it for 3 years. But that's where you need some real expertise. And I went and met with the head of the CMS and the people at FDA, and you make appointments with them and you talk to them about what you're developing, what your problems are, and you try and get them to help you, but it's, at the end of the day, you have to go through the RUC committee and get a CPT code in our case. Now, in some cases, there's already a CPT code, and that makes that part of it easier.
Yeah.
You still have to qualify for it. And that's something that we're talking, we're getting more towards, the end of the show, and they were just starting to talk about that. But if you want to be really smart, you might start with that, work your way back, like Inari did with pulmonary embolus, removal. It's like, whoa, that was really smart, because they already knew there was a bigger reimbursement thing. And so they solved one of the biggest problems that face a company, which is if you're trying to develop it and market it yourself, you need reimbursement. Or if you're going to sell it to somebody, they need to be able, if they buy it, now they spent a bunch of money, they need some way to get it, to pay themselves back for what they bought it for. And so the reimbursement turns out to be super critical. And then physicians really, in today's world particularly, can't afford to do things that they lose money on. And it's interesting how often our system takes a device and they're paying for it. And then, and then every November there's, a new rule that comes out and gets implemented in January, and you may be out of luck. All of a sudden you guys aren't making money, and, they'll stop using your device when that happens.
So how long did it take y'all to get a CPT code after the FDA approval?
We got that in 2020. So we got FDA approval in 16, so 4 years.
Wow.
But it was helped, Wavelength was added at the same time. So that helped, right?
Yeah.
You have two groups, and that's where having competition can help a little bit. It's like
more data, right? Because they were running their own studies, and yeah. It reminds me of the AI space, because we were talking about how they kind of, some of the AI players like Viz and Rad AI, they're in the PE space, right? And they were talking about getting approval and how helpful it is to have a handful of other customers, not too many, but a handful of other ones that are also collecting data. And then it kind of, like the rising tide lifts all boats, because then somebody gets approval and it's like, okay, well, now we can get approval and we can work on something else at the same time,
Right. And it was, unusual. Wavelength had no U.S. data. And so they got FDA approval with OUS data, which is highly unusual. But I think we helped them get, perhaps, no one, it's not like there's a Freedom of Information Act where you can go say, FDA, what were you guys really thinking? But they were like a year ahead of us in terms of their human study. But FDA was dragging their feet. And then our data came in and it was very supportive of percutaneous fistulas. And so they ended up giving us approval first, and then on the same day gave them approval. And I think,
wow.
So just to the point that, you work hard to differentiate yourself from everyone else. But at the end of the day, in the big scheme of things, everybody looks kind of the same. And it's hard to think of it that way when you're in the midst of it.
Yeah. Well, looking back, is there anything that you would have done differently? Anything that was just like, if we had just done this, it would have happened faster, or anything that you think was preventable looking back?
We were pretty lucky. And the problem with a really novel idea is what we just talked about. You have to get FDA approval. You're going to have to do a real clinical trial, not get a 510K approval. And then you're going to have to get a CPT code. And that now is, really a 12 to 15 year process. So I don't think we could have shortcutted that. And we were extremely lucky. These unanswerables sometimes got answered just in time, like the wrist fistula, that idea. Now, the wrist fistula doesn't work, and I'll tell you why. The vein is superficial and it goes over the ligaments to the thumb, and the artery is deep. And between the artery vein are two layers of fat and a layer of fascia. And so as soon as you extend your thumb, it pops, pulls them apart. So actually, one of the first fissulas we did was in the thumb, and it stayed open for about 5 minutes. and then the guy popped it apart.
Oh my gosh.
So you would need something to hold that together, and it's the whole idea of taking a vein and moving it over to an artery and welding it together. It needs something a little more than just a thin rim of tissue to hold it together.
Yeah.
So
and before it was Avenue, was Camus Medical, is that right?
Camus, that's a great story, actually.
Yeah. Tell us what.
Okay.
How that came about.
So the guys that I was telling you about, Mark and Ed, they in Fogarty, they tended to name their companies after wines or wineries. And so we may have borrowed that name from somebody in California.
In the wine. Yeah.
And they decided they didn't like that very much.
Ooh,
so
okay.
So they sued us. And
oh my gosh.
And they for copyright infringement. And then it turns out we didn't want to defend it because we didn't want to have to go to court. Because we couldn't afford it. We spending all our money on this trial. So we came to an agreement where they gave us some large shipment of Special Select and a 5-year thing if we would just change our name. So
that's amazing.
We did. So
yeah,
and it all worked out for everybody. Yeah.
What year was that?
God, that was probably 2012, maybe 2014, somewhere in there.
Yeah.
Sort of in the early years.
Did you hold on to it till you got the CPT code in 2020?
Oh, yeah.
Popped a few?
Oh, yeah. We drank it at the closing party. Yeah.
Nice. Yeah. Which I want to save a little bit of time for the exit to Medtronic. And just, can you tell us, because I think a lot of people, are curious about how that unfolded. Was there, did you guys have to go pitch it to them? Did they come to you? How long do those kinds of transactions take as well?
Well, they could take a long time, and it's tricky. Everyone's waiting for you to run out of money, right? So, if you can start selling, you're not going to run out of money. Fortunately, we had plenty of money. Then you need to have, as they like to say, one buyer is no buyer. You need to have more than one company interested in buying you, because then there's really no market. So kind of like selling a house, JP Morgan, which is one of the really best companies for, selling, startups, is basically the broker. They're the bank that they have a conference every year, and ideas get passed through them, and they help vet you out, so you being vetted out by the FDA, safety and efficacy. You're getting vetted out by CMS in terms of, cost benefit, and you get vetted out by the bankers on the value proposition, right? So you kind of, like 1,000 deaths, you learn a billion things, about all sorts of little nuances that are super, super important. So JP Morgan was our broker, and we had Medtronic was the ultimate suitor that got hold of us, and other big companies were looking, probably not as serious as Medtronic. Medtronic really was our most serious.
I see. Was it something about their culture, their portfolio, that made it especially good fit for Avenue in Ellipsys?
We thought, they had a lot of integrity. We felt that we had really strong data and science behind what we were doing, and that really appealed to them. So we thought that they would do a good job with it. They weren't super strong in the space. I mean, I think they had a good tunnel dialysis catheter, but they didn't have a huge presence like they did in atherectomy world. They had in the OBL world, they were huge in atherectomy, but if you were doing dialysis work, Medtronic was not front and center there. And so I think that appealed to them.
Interesting. And did Wavelength get purchased around the same time by BD?
They got purchased right after FDA approval. And I'm obviously less familiar with the details, but I think they had some VC money, venture capital money, which we had only private money, which is another big, long discussion. Worth talking about. I mean, the venture capital is the people that they're like the loan sharks in the startup world. When you need something, they'll give you the money, but then they're going to take your kneecap when it's time. So they sold like right away to Bard. And then we waited till we'd gotten our CPT code. It was announced. It was in the proposed final rule that we were going to get a CPT code. And then that's when they bought us.
In 2020, 2021.
Yeah, okay. 2020, yeah.
Very cool. And so after that happened, did you have to stick with the company for a period of time?
I didn't. I never, though I worked kind of as their ad hoc chief medical officer, I wasn't getting a salary from them. I really just had stock and ownership, and was like the science guy, was the PI of the pivotal trial. So I did the doctor stuff, and I wanted to keep practicing, just as I was. So I didn't, but all the other full-time employees of the company then went and worked for Medtronic, pretty much. I guess a few didn't, but most did. And that was part of the deal.
And so these days, Jeff, are you working on another device, or are you just practicing? Or
so part of this deal was this blue sky thing, which was, we said, hey, this gets back to a little bit what we talked about. Really, my interest was in a sutureless anastomosis, right? And the fistula was the first iteration. So I had done a deep venous arterialization using an Ellipsys catheter on a patient that really had no other option, and it was successful. And so we were able to created a fistula in the tibioperoneal trunk, drove the flow down the posterior tibial vein to the foot to give a venous arterialization. So, but the catheter was short. It was really awkward to do it. So we were saying, hey, look, we've done this case. We want to pursue this. So they licensed the technology back to us, the Ellipsys technology, for this new application with a purchase agreement on the back end. So that's what I'm working on now.
Very cool. And remind me, I think is there already a CPT code for DVA?
Yes. It's, I think they're getting a pass through for innovative technology so that like the hospital it's expensive, so they get some money. So there's not the official CPT code for DVA, but it's they got approval 2 years ago, LymphFlow. So they're much further along, and they're sort of plowing that ground.
And Inari purchased them, right?
Right.
Yeah. So there's really just one player in that space in terms of a device, I guess.
Yeah, I think so. Right now I think the alternative is off the shelf. People do it with
like August Issa and those guys over in Spain,
right?
Doing a lot of off the shelf stuff.
I guess the problem is let's say you're a company that makes a stink graft, you can't really promote it because you don't have, they don't have that indication. So, they're not out marketing. So there's no one competing against LymphFlow directly on a company level. But, just like the fistula thing, the DVA thing, it's like right now we've been working on, why does DVA work?
Right.
Right?
Yeah. Yeah.
And we think we have the answer, actually. We're putting together a publication of, we're seeing changes on the capillary complex that when you get the venous flow on the backside of the precapillary complex, it seems to promote neovascularity as well as some venodilatation of the spaces that changes the oxygenation of tissue. So it's really cool.
Yeah, it's very cool. It's a cool space to be in because, again, there's DVA is one of the kind of newest innovations I think that everybody's getting excited about in terms of revascularization instead of just crossing CTOs,
Right. And in contrast to the dialysis thing, you're not really competing with anybody. There's not, these patients don't have a good endovascular option. So you're not hurting, and then they don't have a surgical option. And then the wound care guys like it because it makes wound care work, So it's kind of a win-win. So I've found because DVA is a pretty cool idea, but it's one everybody's familiar with. And so it's been much easier to sell the idea of DVA with Ellipsys than with a boomerang, which is the long Ellipsys. Much easier than selling the idea of Ellipsys making fistulas was.
Yeah. And coming back full circle at the beginning, I imagine it checks all the boxes.
Yes. Yeah. There's 100,000 amputations, and many of them are done without any arteriography prior. DVA, it appears to change the physiology in the foot in a fundamental way that doesn't even require that the conduit, whether it's native vein or whether it's a stink graft, down to the foot, stay open. Once you've changed the precapillary complex and dilate the spaces and create a low resistance system, it's like turns it into a sponge, and blood goes down there and does the oxygen exchange, and you get healing. So
it's wild, right?
Yeah.
It just doesn't cause a bunch of swelling, right?
You've done some of those, right?
I've never done any DVAs. I've treated, I've treated PAD patients and lower extremity, C5, 6, severe venous disease with venous edema, and so that I always was wondering, how's it not just cause such severe swelling down there? But I guess because they have a healthy venous return as well, right?
Right. Yeah. You couldn't do it on somebody like that.
Right.
Somebody who's already has venous ulcer. If you had a venous ulcer, it really wouldn't be very
absolutely.
helpful.
Right. Exactly. Yeah.
But it's fascinating. It's like, like I always like to say, every day is a school day. You learn something every day.
Yeah, absolutely. Well, Jeff, we're at the hour. Any final thoughts? We kind of talked about the advice for the docs who have the $1 million idea, but anything else that we left behind parting words for anybody? We'd love to have you back on and talk about some of these other things that we didn't have time for. But, for those guys out there listening that, maybe have that $1 million idea, anything else that we left behind?
No, I think, and I think, if you have a good idea, if you have an idea that's going to help a lot of people, you should pursue it vigorously. It's its own, like I think we touched on it a little bit, it's its own reward, whether it actually is financially beneficial, in a large way. That's really not the only motivation. I think the day-to-day science and understanding of our medical system and reimbursement system and regulatory system, all those things are fascinating, really, and I think there's a tendency in today's world to get very discouraged about this stuff and get angry about it. But I think, you got to get over that. That's where the being 48, 50, having a little maturity might help a little bit. It's not going to be easy, and sometimes people that should be helping you don't, and vice versa.
Yeah, that was my thought when you mentioned whenever anybody says regulatory, it's like blood pressure goes up. I mean, it is infuriating, can be, but you're right. I mean, it's kind of fun. You have to be a problem solver no matter what, right? I mean, That's just part of the process.
And not to say that I did get frustrated plenty,
right.
But I've grown up a little bit.
Yeah. Well, yeah, you get through it, right? Just like anything, learning anything. Like you want to learn the guitar, you get frustrated with your fingers being all clumsy. You get over it, right?
Yeah.
Well, Jeff, thank you so much for coming on the show. Looking forward to hanging out again sometime in person. Hopefully, are you going to be at SIR in Nashville? You think this year?
Yeah, I should be. It's always good fun to get together with you guys. Wouldn't want to miss that. So let's have dinner. Let's do that.
Yeah,
it'll be fun.
Sounds great. Well, thanks everybody for listening.
All right. Thanks, Fritz.
Thank you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend. If you have any questions or comments, DM us at BackTable Innovation on Instagram, LinkedIn, or Twitter. BackTable Innovation is produced and hosted by Brian Hartley,
Aaron Fritz,
Diana Velasquez-Pimentel,
and Eric Amaker.
Our audio team is led by Kieran Gannon, with support from
Josh McWhirter,
Aaron Bowles,
Josh Spencer.
Design and digital marketing led by Brian Schmitz.
Social media and PR by Ann Dang.
Administrative support provided by Jamila Kennebrew.
Thanks again for listening.
See you again next week.